the lower extremities, and y'all really, I feel like you've had enough of brachial plexus that you may feel pretty comfortable going into learning this. Sometimes it throws people it's just hard to look at it, but y'all, I mean, Bill spent quite a bit of time with y'all, didn't he?
It's not showing on.
Yeah, I'm not there yet, but thank you for telling me that.
I think we missed out last semester right before he was about to start.
Oh, so he actually has not, y'all didn't get that, did you, except just, so why did he show y'all the brachial plexus this week?
It was just part of his cadaver.
Okay.
We went over with Kindle with somebody a little bit.
So maybe y'all have it, maybe this, it is better to watch for me. In your book, the lumbar and sacral plexus are on page 25 and 26. And those are the ones that we're going to kind of work from. Those pictures, and we're going to go down our list, but we're going to talk a little bit about peripheral nerves first. Okay. Remember that peripheral nerves are lower motor neuron and they're outside of the brain and spinal cord. And remember that your cranial nerves are peripheral nerves. I think I told y'all about my little friend who had to have her temporomandibular joints replaced. Have I told y'all about her? Well, anyway, on one side of her face, she has no she has no movement in her tongue. So what cranial nerve is that? Hypoglossal. She has no sensation in her tongue or her face on that side. What's that one? Facial, and then no sensation would be the trigeminal. And so I was able to, her mother's freaking out. And the fact that those all three are involved probably means that it's still inflammation. I mean, he might have clipped one of them if it was just one, but because all three of them are involved, it's probably just a lot of swelling still. So because I have that information in me, I was able to comfort that mother. So I'm just telling you, any knowledge is always good, isn't it? So, because they're freaking out, and I don't blame them. It's been 2 weeks, but anyway, because all three of them are involved, then it's kind of a situation like that. Okay, so peripheral nerve injuries have all kinds of causes, but basically it's some kind of pressure on a nerve out past the spinal cord or in the arms or in the legs or the cranial nerves, right? So trauma is probably the biggest thing. Any kind of local tumors in an area, infections can cause that. Injuries to dorsal or ventral spinal roots, so that's right. Remember, your spinal roots are away from the spinal cord, so they're not upper motor neuron, but lower motor neuron and peripheral nerves. And then a real common one is a slip disc or some kind of impingement at the spinal cord area. I mean, not spinal cord, but the spinal root area. So that can be all kinds of issues in the low back, right?
Miss Haldane, on what spinal level does it separate upper motor neuron and lower motor neuron?
L1.
L1.
L1 and above is upper motor neuron, and L2 and below is lower motor neuron.
Okay, because I think I saw one of the questions on the test was like that.
Okay. One of the things I would tell you is there are anomalies, and occasionally you will have a upper motor neuron that's an L2. Anomalies in the body are pretty common, and so not everybody's made the same, but we're going to go across and say L1 is upper motor neuron. You do see that occasionally. Okay, so if you happen to have a dorsal root lesion right there next to the spinal cord, and before that dorsal root would be part of that spinal nerve or that spinal root, you're going to have sensory loss, but you don't have atrophy, you just have decreased coordination of the muscles, because that sensory information is not able to get in to maintain normal muscle control. So you do see these sometimes. And it would just be in the peripheral system, we're just talking about the muscles that are connected to that particular nerve, right? If it's just one dorsal root lesion. Some different peripheral nerve injuries that you need to know and you may work with. Herb palsy is when a baby is born, and normally what happens is there's too much pressure put on the shoulder during birth, and so it pulls down, and so you have a C5 and 6 nerve root involvement. So if you have that, I mean, literally it's a pulling down. So some of these are brachial plexus, by the way. So this would be a brachial plexus injury. So what would you lose in the arm that we know about?
Sensory of the deltoids and thumb.
The deltoids wouldn't be working, your biceps wouldn't be working, your brachioradialis wouldn't be working, your wrist extension wouldn't be working. You've lost your sensation in your thumb, right? Some of the sensation up there. So that's just an example, but that's herb palsy. That's what that's called. Klumpke's paralysis is when the baby is born with the arm over their head, and so it pulls up in this direction. So you have damage at C7, C8, T1. This is actually more common. I believe that there's a big decrease in these two problems, and why is that? C-sections. We do lots of C-sections. And I'm all for C-sections if you don't have trouble with the baby. I mean, I hate for mamas to have to go through that, but I'm for them. And so you're seeing less of this, but I do run into it. I had a friend whose little girl had Klumpke's paralysis. She completely recovered, which is a real common thing. As long as it's not severed, they a lot of times will start working with them, and within a year they'll have all of these movements back. So with Klumpke's paralysis, what would we lose? We'd lose the triceps for sure. What's the C8T1? Pretty much the lumbricals. You'd lose the interossei, you'd lose quite a bit of hand movement. You'd lose flexion of the fingers, the wrist. You would lose the sensation like the ulnar nerve. C8T1's over on the half of the ring finger and the little finger. We'll talk about that as we get more into the brachial plexus. Okay, so those two, and that's usually what causes them. Carpal tunnel syndrome is a median nerve compression, and that's compression with the transverse carpal ligament, and it also can involve the ulnar nerve. This was a question on the licensing exam years ago. They would say, what's the other nerve possibility of involvement if you have carpal tunnel? And it's ulnar nerve, so now you'll know that, because it comes down here too, but it's normally the median nerve, okay? It's usually the median nerve. So we will talk about more about the carpal tunnel syndrome and what you see. What does the median nerve do muscle-wise? It just does this right here, these three fingers. So that's median nerve.
How does it affect the ulnar nerve? Because we literally just talked about how the ulnar nerve is the only one that doesn't affect, like in the cadaver, because it runs over here.
Right, but I have no idea. I'm assuming through a lot of inflammation over that transverse nerve. I never thought of it being, I've never had a patient that had it affected. It for sure can't be the radial nerve, so that was a question on the test. So that's why I put it on here. Literally,
good to know.
it would have to be, I don't know, I've never seen it before. So, thoracic outlet syndrome is something else that can cause lots of problems. It's an entrapment syndrome caused by pressure from structures, and it's usually right through here. And a lot of times it's caused by an extra little rib sticking out. It's about that. It'll stick out on one side, and it's real common. So it puts pressure on the brachial plexus and normally there's also vascular symptoms, and because of pressure on the subclavian artery, the first rib can be involved, the scalenus anticus and medius, which are these right up in here, are the scalenes. And then the brachial plexus, the subclavian artery, and the subclavian vein. So all of these things can be involved. And it's just because of this compartment that's so small. So if you start getting any kind of issues with that, there's ways of testing for that Bill can show you, because it's kind of an orthopedic thing. It's kind of hard to diagnose, but actually what happens is when you turn the arm a certain way, you'll feel a decrease in the brachial pulse down here. They have certain sensory issues that go with it. They have a lot of pain, usually down just right in this area, and sometimes weird pain. But anyway, thoracic outlet syndrome is a peripheral nerve injury if it puts pressure on those nerves. Okay, here's just some terms that you need to know. Saturday night palsy is when you have damage to the radial nerve, and the radial nerve comes right over the shoulder, and we're going to talk about that when we get the brachial plexus. But what happens is Saturday night palsy is when a drunk is so drunk that he sleeps 24 to 30 hours before he wakes up, and he literally, if someone doesn't lay him out flat, he can get bed sores, by the way. They don't move. They literally do not move. So what a Saturday night palsy is when they've gone to sleep on that arm, and it literally can completely kill off all the radial nerve stuff. I've even had a patient that they had to amputate the arm above the elbow because it also cut off all his vascular things. So that's usually what it is someone and it's called Saturday night palsy. It's just what it is. And it's usually radial nerve damage. Neurotmesis is a total severance of the nerve. And so that means literally that peripheral nerve has been severed. But the neat thing about what is happening in this day and age is they can put those nerves back together. I mean, they literally can put a hand back on, and it will function, not normally, but function. And so they can go in and do a lot of work with nerves and fix that. But if it's severed, and let's just say you don't have any, and it happens in Africa, and they don't have a doctor that knows how to do that, there's nothing there. It's flaccid. You've got atrophy of the muscle, no sensation below that level, and all of those things. So that's a neurotmesis. Neuropraxia is a segmental demyelination which slows or blocks conduction of the action potential at the point of demyelinization of a myelinated nerve, and that can be all kinds of issues, disease processes, and things like that. A Trendelenburg gait. We need to talk about this. Has Bill or anybody talked to you about a Trendelenburg gait? What that is that's when you have a dropping of the hip secondary to a gluteus medius damage on the opposite side. And it is a superior gluteal nerve or fixed and learn. But what it is, remember that the gluteus medius, what does it do? Hip abduction. And then, but the reverse movement that it does is it lifts up this other hip. So see that it keeps this hip from dropping. So let's say I have a weak left gluteus medius on the left, and so when I walk, this hip drops because this is weak. So that is a Trendelenburg, okay? Trendelenburg gait. If you see it on both sides, you'll see them drop both hips when they walk. It's kind of hard to do that, but they drop both hips. And you can see it, where you see it a lot really is in a stroke patient, even though that would be a peripheral nerve. They drop the gluteus medius with a stroke. It seems to be affected a lot, even in a minor stroke patient. So you'll see that hip drop on that good side. It's when you're, on the affected side, when you take that step, the other hip drops, okay?
That's all good. Is neuropraxia the same as MS? Or is MS
I would think that probably fits into that with the peripheral nerve. MS can also affect the central nervous system, so it's probably more of a central nervous system. I don't know, because I don't think about MS as being peripheral very much, but it certainly can be. I'll look that up and see, because you don't see a lot of peripheral damage with him. You see more spasticity, stroke-like symptoms, that kind of thing.
Okay.
With MS, isn't it lesions on the brain?
But it's in the lesions in the brain in the myelin.
Okay, so it would be, central nervous system?
Almost always it's central nervous system. I don't know about the peripheral. I'll look that up. Genu recurvatum is a term you need to know. What is genu in Latin? Anybody know?
Knee.
That's knee. Recurvatum means that you hyperextend the knee. So your recurvatum is backwards. And so hyperextension of the knee, and this is when the femoral nerve is weak. And so anytime you have somebody that locks in their knee when they walk, they have genu recurvatum. That's a term that you need to know, because you're going to see it. It's just an accepted term that's what you do, but it's basically backlocking the knee. What muscle is weak when that happens? Quadriceps. Even if it doesn't make sense to you, it's the muscle that's weak, because they can't control that knee. They can't control the knee, so they're locking that knee in every time. So if the quad is weak, that's what's happening. What type of patients do you have to watch for that?
Stroke.
Stroke, that's one.
Total knee.
Well, total knees actually you don't, because that mechanism is made to do that. And actually, I have them walk like that initially. I'm more interested in them getting that knee straight than I am bent. So when I have them actually lock their knee in when they walk initially. So, you do have to watch like your arthroscopies, and you have to watch your total knees if has Bill ever told you what that's called when the quadriceps muscle just goes to sleep?
No.
I'm gonna go get that term right now. Surely Kendall knows.
I don't think so.
Great.
Oh, no.
I can do that, but I don't know.
Mine looks
what
just
you're
like that.
referring to.
Yeah, when I'm in there, but I'll get that term for us, because I don't.
It's on the slide.
A real common thing that happens when you have knee surgery is that quadriceps goes to sleep. It doesn't matter what kind of knee surgery you have. So the most important thing for you to do is to make sure that you get a quad contraction. What do people substitute for a quad contraction? Have you had this in your class, in
It's
clinical?
the glutes,
The
right?
glutes. So what they do, we teach them glute sets and quad sets at the same time. Don't do that. They need to do their quad sets separate from the glute sets, okay? Because what they do is they push their knee down into their ankle down into the bed, and you think you're feeling a quad set. They're not even using their quads. So how do you make sure it's a quad set?
Feel the quad.
Well, you put your hand on it, but you also put your hand underneath and you say, okay, what I want you to do is don't put any pressure into the ankle, but push down into my hand with your knee. And you know what? A lot of times they'll just barely feel it. I cannot tell you the number of patients I've had who've come from rehab centers and different places who they missed it. Put your hands on a quad with a knee patient and make sure it's firing. That makes you a bad PTA if you don't do that. If you have a knee patient and they come to me in home health, I might even call you and say, what happened to you? Okay? You watch for the quad. I see it a lot, guys. You should not miss that. I see it a lot. Okay. Any questions on those?
I had a question about Erb's palsy. It is the one where like one shoulder is just drooping, right?
I don't know that it would look like a droop because your deltoid's gone. So yeah, it would probably be lower. Okay, I have books up here. If anybody doesn't have the neuro book, because we need to look at the lumbar plexus. Does anybody, that's where the pages on this particular thing come out of this book. And it's gonna be different than some of these others. That one will be correct.
I left mine at home. I think,
And it's also in your neuro book too.
I think I left mine.
I just don't have
tried,
pictures
but I
of
don't
those
know.
up there. It'll help you if you have it. So we're gonna start with the lumbar plexus, which is the most simple. And it is on page 25 of your book. And we're gonna start up at the top. So just look up the lumbar plexus and look where it's at. And we are looking at the ilioinguinal nerve. The spinal levels for the ilioinguinal nerve are L1, 2, 3, and 4. And basically it's just segmental innervation of your stomach muscles, your obliques and your transverse abdominis. So L1 comes in, and then L2, and then L3, and L4. So it's all of these all the way down to the pubic bone. So you just have, and this is where it comes off. Although you can't really see how that comes off, you're just gonna have to trust me. You can't see it on that picture. But that is what its purpose is for. Is it innervates your stomach muscles, L1, 2, 3, and 4, okay? The lumbar plexus, what we have there is the nerve for the psoas major and psoas minor. And if you'll look in the book, it shows you where those come off. And basically, it's just L2 and L3. And the reason why they put that is they have not even named those nerves. And the reason being is those muscles are so close to the spine that it literally comes off the lumbar plexus. Okay, so it's the lumbar plexus, L2, L3. For your psoas major, your psoas minor. Okay, so let's look at the femoral nerve. Y'all really need to see these. Does anybody not have their little books? Let me go see what I have.
They're in the anatomy book too.
Oh, they're in the anatomy book. So I need you to look at your femoral nerve in the anatomy book.
What page is it on?
68. Or
It's also in the little
Starts.
book. In your little book, it's got the femoral nerve. So look it up first. Your two big nerves coming off the lumbar plexus is the femoral and the obturator. And the way the lumbar plexus comes down is it comes out of the lumbar area and goes down in front of the pelvis and innervates kind of to the front. Everybody looking at the femoral nerve? See how it comes off and connects to all those muscles? It's L2, 3, and 4. And it does the iliacus. What's the iliacus's function? It's a hip flexor, so it's major and minor. They're all kind of there together, right? Iliacus and psoas major and minor, they're your hip flexors. You might want to write hip flexion out to the side there. You might want to put it next to your stomach muscles. Flexion, mainly your muscles are support, right? They're more your core strength. Psoas major and minor, hip flexion, iliacus, hip flexion. What does the sartorius do? It is that neat little muscle. It's just fun. This is the one I like to see on bodybuilders because it's the one that comes from the hip and goes around to the inside of the knee. So it does flexion, external rotation. What else is it? Flexion, external rotation. I know there's one more thing that it does, but anyway, it's the one that does this movement. What else am I doing there? Flexion, abduction. Abduction, that's what it is. So that's your sartorius, so go back and look at that one. And then your pectineus is a little bitty muscle. We don't have to put too much emphasis on that one. And then your quadriceps femoris. So that's the biggie that the femoral nerve does, right? So it comes off, and that's the iliacus, sartorius, pectineus, and quadriceps femoris. And what's the quadriceps do? What's its main function? Knee extension, what else?
Hip flexion.
Hip flexion. Main function of knee extension, okay? Okay, obturator. Look at the obturator. Everybody see a picture of the obturator? It comes right down the side, and you can see it coming off of the, it comes off pretty much right next to the spinal cord and goes straight down to the adductors. So it does all of your hip adductors. And then it does the gracilis. What is the gracilis muscle? It's that little bitty skinny muscle. It's just like a strand that goes from your pubic symphysis down to your knee. And it adducts. It's a little bitty tiny muscle, but anyway, it's there. It can cause problems at times. And then all three of your hip adductors is obturator. So that's all the lumbar plexus. There's not a lot to it, but you need to know it, right?
What about this genitofemoral?
The what?
Genitofemoral?
Genitofemoral is a sensory nerve for the genital area.
Okay.
And we're not doing any sensory nerves, we're just doing dermatomes. But you can know it if you want it. So these are the four you're responsible for me. And I think it's the only one they'll actually, all of these are also sensory nerves, by the way, but we're not doing any, unless you don't want to memorize all those nerves and what they innervate. The other ones we'll actually do are your hand, because you need to know the radial, median, and ulnar. But other than that, it's all dermatomes for sensation. And that's how we function, really, in the PT world.
So what do you think we need to focus in on these?
You need to know the nerve, you need to know the spinal levels, you need to know the muscles, and you need to know what the muscles do.
Okay. Oh, the paper?
Sounds familiar, don't it?
Okay.
Is that Bill Carroll?
Yeah.
Bill, come here! What is it called? Oh, both of y'all. What is it called when the quadriceps goes to sleep during a surgery? What is that term? You remember?
That's unofficially it's called quad shutdown,
Quad shutdown.
but that is not an accepted medical term for it.
Is that what people are gonna call it in the clinic?
That's what we called it in our clinic. What did you call it?
We're gonna go with quad shutdown. Is there another term? I mean, is there an official?
I don't know.
Okay, the other thing is the Trendelenburg thing. I never remember, so if the hip drops
The opposite side.
Elevated side is the weak side.
right, but what is it? Is it Trendelenburg on the left or right?
You name it for the side
To the side of the weakness.
to the weakness.
Okay, so when you're dealing with Trendelenburg, you name it to the side of the weakness. That means the muscle, that's when the medius gives up, and if what Bill's doing right now is,
Right from the
right, Trendelenburg. You have to, we've gone around and around on this Trendelenburg thing for years, so I always forget because,
The glute med,
You name it for the side of
100%
weakness.
glute med,
Okay.
and it's actually in a closed connect chain. Actually, the open connect chain is here.
The question that we really need to go into is, which does better for it? An isometric training regimen or an eccentric training regimen?
Let's say eccentric, because you need to strengthen it.
Throwing that out there for you to chew on.
And when you see somebody walking like this,
What do you think, Lindsay?
it's usually not a double.
You don't think that's true? You're saying Ryan
Usually
is
a learning
wrong?
gait.
My first thought was isometric.
I say eccentric.
This is a really good eccentric move right here. Watch.
What do you call that right there?
Eccentric hip abduction from stance face.
With the right gluteus medius.
Because if it were working, it would work in an isometric contraction right here. But then eccentrically, as you bring swing phase through in the opposite leg, here's where it drops. It's toughy in here.
Can I ask one more question?
Absolutely.
During quad shutdown, the vastus medialis selectively atrophies quicker than the rest of the quadriceps muscle. What does that have to do with the concurrent resultant forces on the patella?
Stable as water. Did you get hold of some bad hail? That's how I got food poisoning one time.
Where'd you get it from? What? Where'd you get food poisoning from?
It was the chocolate bar.
Did you call them and tell them?
No, I should have.
Can we agree that these are concurrent forces acting on the patella?
Yep.
This one gets weaker, what's gonna happen? What's the resultant force gonna be? That's all I asked you, but I just asked you without the visual. And that has implications in a condition called chondromalacia patella, or patellar tracking problems, which I saw a kid yesterday for. Kendall was right there when I evaluated. He didn't even lay hands on him and he knew what was going on. Ooh, isn't it amazing how all three of our courses tie together?
I actually saw somebody with that had an arthroscopy done a year and a half ago, and he had part of the patella removed, and then they shaved off the bottom of the patella, and he's still got a lot of pain. They didn't send him to therapy, didn't do any exercises. So what do you think's weak on him? The medius. He's got a lot of pain, so we didn't even get a referral for the knee. It was mainly for his back. Probably messed up the back too. So you always look at the medius with a new patient.